Craniopharyngioma treatment involves several medical strategies used to control a tumor that develops near the pituitary gland at the base of the brain. The focus of this presentation is on three core approaches: surgery, radiotherapy, and hormonal therapy, each addressing a different part of the disease process. Before moving further, you may consider joining the StudyNeuro community, a platform that shares focused neuroscience education and practical clinical insight for students and clinicians interested in brain and nervous system disorders. Now to the purpose of the session. By the end of this presentation, learners should understand the main treatment approaches used in craniopharyngioma, how surgery and radiotherapy help control tumor growth, and why hormone replacement becomes necessary when pituitary function is impaired. Craniopharyngioma is a benign tumor that develops from epithelial remnants left behind during the early formation of the pituitary gland. Although the tumor itself is not malignant, its location near the hypothalamus and the optic pathways places it next to structures that control vision, hormonal balance, and several basic body functions. The tumor usually arises in the sellar and suprasellar region, the area around and above the sella turcica, where the pituitary gland sits, and even slow enlargement within this narrow space can compress nearby structures and disturb normal neurological and endocrine activity. Several important structures lie close to the tumor. The optic nerves and optic chiasm carry visual information from the eyes to the brain. The hypothalamus regulates temperature, appetite, and hormonal signals. Just below sits the pituitary gland, which releases hormones that control growth, metabolism, and reproductive function. Pressure in this region causes problems. As the tumor expands, patients may develop visual loss, hormone deficiencies, or sometimes changes in memory and behavior, particularly when the hypothalamus becomes involved. Because more than one system is affected, management usually requires collaboration between different specialties. Neurosurgeons remove tumor tissue when possible, endocrinologists manage hormonal problems, while neuro-oncologists and radiation oncologists guide additional tumor control with radiotherapy. Radiologists also play a central role through imaging and follow-up assessment. Treatment therefore rarely relies on a single method. Management often combines surgical removal of tumor tissue with other therapies that control remaining disease, especially when complete removal risks injury to nearby structures, and radiotherapy can help stabilize residual tumor growth in such situations. Hormonal therapy also has a key role. Hormone replacement is required when pituitary function declines after tumor growth or treatment, and with improvements in microsurgical technique and modern radiation planning, long-term tumor control has improved while helping preserve surrounding brain structures. Surgery is still the main treatment for most patients with craniopharyngioma. Its purpose is not just to remove tissue, but to relieve pressure on nearby structures and confirm the tumor type under the microscope. Complete removal is not always safe. The tumor often lies next to the hypothalamus and optic pathways, so surgeons aim for maximal safe resection rather than aggressive removal that risks serious complications. There are two main surgical approaches. One is called gross total resection, where surgeons try to remove all visible tumor. This can be effective, but when the tumor is tightly attached to critical structures, attempting total removal can cause significant neurological or endocrine problems. The other approach is subtotal resection combined with radiotherapy. Here, part of the tumor is removed, enough to relieve pressure and improve symptoms, and radiation is used to control the remaining disease. Studies and experience show that this strategy often preserves function better while still managing tumor growth. In many cases, balancing tumor control with preservation of vision and hormonal function is the priority. Surgeons must decide carefully how much tissue to remove, always considering the delicate structures that lie right next to the tumor. Proper preparation before surgery is essential. It reduces the risk of complications and helps patients tolerate the procedure better. One major concern is hormone problems, especially when the adrenal glands are not working well, because this can make blood pressure unstable during surgery. Another issue is swelling around the tumor, known as peritumoral brain edema. This swelling can increase pressure inside the skull and make surgery more difficult, so controlling it beforehand improves safety. Hydrocephalus, or fluid buildup in the brain, is also important. If it is present, pressure needs to be managed before or during surgery, otherwise the patient may experience worsening neurological symptoms. Large cysts within the tumor are another factor. They can distort surrounding structures, and sometimes draining or reducing them first during surgery helps the surgeon work more safely. Addressing these conditions ahead of time improves both immediate surgical outcomes and long-term recovery. Minimally invasive surgery refers to techniques that allow surgeons to reach the tumor through smaller and more direct pathways while reducing disruption to surrounding brain tissue. In craniopharyngioma treatment, these methods often involve the transsphenoidal corridor, which provides access to the cellar region through the nasal cavity. Several surgical variations are used. One common method is the endoscopic endonasal transsphenoidal approach, where an endoscope is passed through the nose to reach the tumor, allowing the surgeon to operate with a wide, illuminated view of the surgical field. Another technique is the extended endoscopic endonasal approach. This method expands the surgical corridor by removing additional bone above the sella, which allows access to tumors that extend upward into the suprasellar space, while still maintaining a direct midline route. The microscopic transsphenoidal technique is also used. In this procedure, surgeons operate through the same nasal corridor, but rely on an operating microscope rather than an endoscope for visualization. These procedures are particularly useful for tumors located mainly within the sella. They are also helpful when cystic craniopharyngiomas extend upward into the suprasellar region, because the midline approach allows surgeons to reach the lesion without significant manipulation of the brain. By approaching the tumor through the natural nasal corridor, surgeons avoid large cranial openings and limit the need for brain retraction, which helps reduce trauma to nearby neural structures. However, complications can occur. One important risk is cerebrospinal fluid leakage, which happens when the protective membranes around the brain are open during surgery and fluid escapes through the surgical pathway. Careful reconstruction of the skull base is therefore essential. Transcranial surgery refers to operations performed through an opening in the skull in order to reach deep brain structures. In craniopharyngioma treatment, this type of approach becomes necessary when the tumor is large or extends beyond the reach of minimally invasive routes, particularly when it grows upward into the suprasellar region or the ventricular system. These cases can be technically demanding. Several operative pathways are available. The pterional approach provides access through the frontotemporal region and allows the surgeon to reach tumors near the optic nerves and carotid arteries. The orbitozygomatic approach extends this exposure by removing additional bone around the orbit and zygoma, which improves visualization of deeper structures. Other routes pass through the ventricular system. In the transcallosal transventricular approach, surgeons enter the lateral ventricle through the corpus callosum and then reach the third ventricle. The transcortical transventricular pathway instead passes through the cerebral cortex before entering the ventricular cavity. These corridors give wider exposure. Selecting the appropriate route requires careful evaluation. Tumor size influences the degree of exposure required. Tumor location also matters, especially when the lesion extends into the third ventricle or attaches closely to nearby neural structures. The surgeon's experience plays a role as well. The overall aim is clear. Surgeons try to remove as much tumor tissue as possible while protecting nearby structures that control vision, hormone production, and higher brain function. However, these operations carry risks. The hypothalamus sits very close to many craniopharyngiomas, and injury to this structure can lead to severe metabolic and behavioral disturbances. Damage to the pituitary system may also result in long-term endocrine dysfunction, and in some patients, neurological complications or tumor recurrence may still occur despite careful surgical technique. Cerebrospinal fluid diversion refers to medical procedures that redirect the normal flow of cerebrospinal fluid when it becomes blocked. In patients with craniopharyngioma, this problem may occur when the tumor obstructs fluid pathways and causes hydrocephalus, a condition where fluid accumulates inside the brain and raises intracranial pressure. Pressure rises quickly. Two procedures are commonly used to manage this situation. One option is the ventriculoperitoneal shunt, a system that drains cerebrospinal fluid from the brain's ventricles into the abdominal cavity, where the fluid can be absorbed safely. Another option is external ventricular drainage. In this procedure, a catheter is placed into the ventricular system and connected to an external collection chamber, which allows temporary control of intracranial pressure while the patient is monitored closely. These procedures act mainly as supportive treatment. They can reduce intracranial pressure rapidly and stabilize the patient before more definitive tumor treatment is performed, particularly when surgery must be delayed or when neurological symptoms worsen because of fluid buildup. However, these techniques do not remove the tumor itself. Complications can also occur. Infection may develop along the drainage pathway, and shunt systems sometimes malfunction or become blocked, which can lead to recurrent pressure symptoms and the need for further intervention. Radiotherapy is a treatment method that uses focused radiation to damage tumor cells and slow or stop their growth. In craniopharyngioma management, it is commonly used after surgery when a small amount of tumor remains, or when the tumor grows again after earlier treatment. Its role is supportive, but important. The main purpose is to control residual tumor tissue that cannot be removed safely during surgery. Radiotherapy can also stabilize recurrent disease, particularly when another operation would carry a high risk of injury to nearby brain structures. Several radiation techniques are available. External beam radiotherapy delivers radiation from a machine outside the body over multiple treatment sessions, while more advanced methods such as intensity-modulated radiotherapy shape the radiation beam so that the dose follows the tumor contour closely. Other highly precise techniques exist. Stereotactic radiotherapy delivers targeted radiation using detailed imaging guidance, and proton beam therapy uses charged particles that release most of their energy at a specific depth, which helps limit radiation exposure to surrounding brain tissue next to the tumor. These methods improve safety. Radiotherapy offers effective tumor control without the need for additional surgery, and modern planning systems reduce radiation exposure to nearby structures, such as the optic pathways and hypothalamus, particularly when proton therapy is used. However, risks remain. Radiation close to the optic nerves may affect vision if the dose is too high. An injury to the pituitary gland or hypothalamus can lead to hormonal problems that require long-term replacement therapy. Late effects such as vascular injury or secondary tumors have been reported, although these events remain uncommon with current radiation techniques. Intracystic therapy refers to treatments delivered directly into the fluid-filled cavity of a tumor. In craniopharyngioma, many tumors contain cysts, which are pockets of fluid that enlarge and compress nearby brain structures, sometimes even when the solid tumor portion remains small. Cyst growth can cause major symptoms. This approach is most useful when the tumor is mainly cystic, meaning the cyst component forms the larger part of the lesion. It is also considered in patients who develop recurrent cysts after earlier treatment, or in individuals for whom major surgery carries significant medical risk. Several treatment options exist. One method involves placing radioactive material directly into the cyst cavity. Radioisotopes such as yttrium-90, phosphorus-32, or rhenium-186 release radiation locally and damage the cyst lining, which reduces fluid production and helps shrink the cyst. Another approach uses intracystic chemotherapy. In this technique, drugs such as bleomycin or interferon alpha are instilled into the cyst space to suppress the cells that produce cyst fluid. Repeated drainage is sometimes needed. For that reason, surgeons may insert an Ommaya reservoir, which is a small catheter system placed into the cyst cavity and connected to a reservoir under the scalp, allowing fluid to be removed or medication delivered without repeated surgery. The main benefit is minimal invasiveness. These treatments can reduce cyst size effectively and may delay the need for larger surgical procedures, especially in patients where preserving surrounding brain structures is a priority. However, risks remain. If the drug or radioisotope leaks outside the cyst cavity, surrounding neural tissue may be exposed, which can lead to neurotoxicity, and in some cases, visual or neurological complications have been reported. Hormonal replacement therapy refers to the medical treatment used to restore hormones that the body can no longer produce in adequate amounts. In patients with craniopharyngioma, endocrine problems are common because the tumor often affects the pituitary gland and the hypothalamus, which together regulate many essential hormonal functions. Hormonal deficits appear frequently. The pituitary gland controls several endocrine pathways, and when its function declines, patients may develop adrenal insufficiency, thyroid hormone deficiency, or problems with reproductive hormone production. Growth hormone deficiency may also occur, particularly in children whose normal development depends on adequate hormonal signals. These changes affect many body systems. Adrenal insufficiency, for example, reduces the body's ability to respond to physical stress and maintains stable blood pressure, while thyroid hormone deficiency slows metabolism and can lead to fatigue, weight changes, and reduced mental concentration. Treatment focuses on replacing the missing hormones. Hydrocortisone is commonly given to correct adrenal hormone deficiency, while levothyroxine replaces thyroid hormone when the thyroid axis becomes impaired. Additional therapy may be required. Children with growth hormone deficiency may receive growth hormone therapy to support normal physical development, and patients with reproductive hormone deficits may need sex hormone replacement to restore normal physiological function. Long-term monitoring is essential. Endocrine care usually continues throughout the patient's life because hormone levels can change over time after tumor treatment or surgery near the pituitary region. Surgical removal of craniophryngiomas can be challenging. Reported rates of complete tumor removal, or gross total resection, vary widely, from as low as 10% to as high as 90%, with an average around 58%. Complete removal is not a guarantee. Even after surgery, tumors often recur. Recurrence is more likely when only part of the tumor is removed, but it can still happen in 6 to 57% of cases, even after gross total resection. For this reason, combining surgery with radiotherapy is common. Using both approaches improves long-term tumor control while balancing the risk of damage to nearby brain structures, which is crucial given the tumor's location near the hypothalamus and optic pathways. Managing craniopharyngioma is complex. It requires a treatment plan that uses more than one method. Surgery remains the mainstay, aiming to remove as much tumor as safely possible. Radiotherapy plays a key role when tumor tissue remains or the tumor comes back, helping control growth while minimizing damage to surrounding brain structures. Cystic tumors may benefit from intracystic therapies, which can reduce cyst size and sometimes delay the need for major surgery. Hormonal replacement is also essential. Patients often lose pituitary function, so replacing missing hormones supports long-term health and quality of life. Careful planning is critical. Balancing tumor control with protection of neurological and endocrine function is the goal of any treatment strategy. Join the StudyNeuro community for focused neuroscience education and clinical insights. Follow us on YouTube, Facebook, TikTok, Instagram, and X. Like, comment, share, and subscribe. Thanks for watching, and stay tuned for more updates.